Hey, you know what? After making literally over 100 videos just to address the enlarged prostate for patients, I realized I never talked to primary care doctors regarding enlarged prostate. And I recently came upon a survey of primary care doctors and why they don't send patients to urologists to take care of the patient's enlarged prostate. So in this video, I'm going to quickly address 5 concerns that primary care doctors, when surveyed, said that were major big issues why they don't send their patients to the urologist. So for those of you watching who are not in healthcare, pardon my use of jargon, and let's get right into it. So enlarged prostate, or BPH, affects over 40 million men every single year in the United States alone. There simply aren't enough urologists to take care of all of these patients. But interestingly, I see a lot of men who come in very late stages of their enlarged prostate when their bladders completely failed. They no longer have the ability to void, and they go into urinary retention. They have to go to the ER and have a catheter inserted, and then they come to see me. By then, it's already too late. And as you all know, as primary care doctors, this is a progressive and insidious problem. Unless you ask, the patients are going to tell you, these guys are going to tell you, nope, everything's fine. Continue my medication. So some of the questions that, some of the issues that primary care doctors have, here's apparently one of them. Number one, the patient does not want surgery. Okay, let's talk about the treatment options for enlarged prostate. You can do nothing and ignore it. You can put a Band-Aid and give medication or medications to patients, but they all have side effects. For instance, if you prescribe tamsulosin, it's going to cause retrograde ejaculation, nasal congestion, possibly associated with dementia, and also 5-alpha reductase inhibitors like finasteride, they can cause permanent erectile dysfunction, also known as post-finasteride syndrome. So also, they can't donate blood while they're taking medical therapy. Besides, the medications are Band-Aids. They don't cure the underlying problem, which is an enlarged prostate. So you can put a Band-Aid on things and make the patients feel better, but eventually, as I tell my patients, if you're lucky enough to live to an older age, then you'll have the privilege to see a urologist. Eventually, most men will come in and see us anyway, and my goal is to make sure we take care of them before their bladders completely quit working. They go into urinary retention, have bladder stones, recurrent UTIs, and then they require major, much bigger surgery and longer convalescence. So when you say that patients do not want surgery, you're probably thinking the urologist only has TURP, or transurethral resection of the prostate, to take care of the patient. Nothing could be further from the truth. We also don't need to do a laser prostatectomy. We do not need to do a simple prostatectomy or robotic prostatectomy. We do not need to do any of those invasive procedures requiring the use of hospitals. And patients, and even if you're thinking about a TURP, patients, in my hands, patients go home the same day. Yes, they do have to wear a catheter. It is uncomfortable. But even when you're talking about TURP as a surgery, patients get to go home the same day, they wear a catheter briefly, and they recover extremely quickly. Now, let's get off of surgery. There are treatment options for enlarged prostates that do not require the operating room, meaning there are minimally invasive surgical treatments, MISTs, as urologists would call them, that are available, that are done in the office. For instance, today I performed 6 of these procedures. The patients literally came in and walked out, and they had their prostates treated without having to wear a catheter. They immediately stopped their 5-alpha reductase inhibitors and alpha blockers today, the day I treated them. And you know what happens? I send the patients back to you after I take care of them, after I cure them, because I do not want to keep your patients. I do not want to keep your BPH patients, believe it or not. Okay, I send them back to you as soon as I cure them. So you don't, that if there's a concern about that, you do not need to be concerned. I do not keep your patients. All right, so there are minimally invasive procedures available in the office that can be done that do not require the hospitals. Because right now, during the current situation with the virus, I personally want to avoid the hospital. I want my patients to avoid the hospital. So what better way than to take care of them and avoid the OR by doing a procedure right here in the office. Minimally invasive procedures are available. So surgery is not really a thing and is not really the only way to take care of an enlarged prostate when you send the patients to the urologist. All right, second concern. PCP, you can prescribe medications. Well, like I mentioned, it is a Band-Aid. When I perform a cystoscopy on a patient, after he's been on years of alpha blockers and 5-alpha reductase inhibitors, guess what? The prostate still looks obstructive. It is still, he's voiding through a tiny non-existent opening, like a little slit. Try to get urine through a little slit. That doesn't even, there's no opening when I look into the prostate. So we are fooling ourselves by putting a Band-Aid on the situation. The patient feels better, but the underlying problem is still there. So medication is available, and unfortunately, I see the patients in later stages of bladder dysfunction from a chronic obstructive voiding symptoms due to enlarged prostate, due to BPH. I see changes within the bladder trabeculations, and guess what? They don't ever go away. They do not heal. Once they develop, these collagen deposits and buildup occurs within the bladder wall, that's done deal. It doesn't go back to normal. So we are simply delaying the inevitable for a lot of these patients. And also the bladder over time, one of the worst case scenarios is to have the bladder completely fail, meaning the bladder no longer, the detrusor muscle no longer has the ability to contract to empty the bladder. So this guy is having to do self-catheterization or wearing a Foley catheter chronically, suprapubic tube and things like that. Talk about a horrible way to live, horrible quality of life. So anything I can do to avoid that, I am going to do it. All right, third concern for primary care doctors. They do not want to waste the patient's or my time. Well, I will assure you that you are not wasting my time when you send your patients here to see me. I mean, I have gotten worse consults than BPH requiring additional workup or treatment. If we can cure these patients with an outpatient procedure done in the office, come on. It's awesome. You're not wasting my time, trust me. And as far as wasting the patient's time, so I've said this numerous times before. One, we value our money, and two, we value our time. And the way we operate here is that we respect the patient's money and we respect the patient's time. Typically when I see it in a BPH patient, the first visit, I get their history, I perform a physical examination. The second visit, typically a cystoscopy or a transrectal ultrasound. Third visit, most likely they're having a definitive treatment. And then fourth visit is typically now a telemedicine visit. The patient doesn't even have to come into the office. So in 3 to 4 visits, I'm curing the patient, and he no longer needs to keep coming back to see me. And then he can go back to see you, the primary care doctor. So we definitely respect the patient's money and time when we work them up to take care of their BPH symptoms. Okay, fourth complaint or fourth objection, it requires an extra copay. Well, a lot of our BPH patients are in the Medicare age, and when they have Medicare in the secondary, it's completely covered. So there's no additional copay. And as I just said, we will do everything we can to minimize the number of times the patients have to come to see us, because we value their time just as much as we value our time. We don't want to waste their time, just like we don't want them to waste our time. So rest assured, we get them taken care of without wasting their time or money. And lastly, of course, coming to the urologist, going to see you as a primary care doctor requires the patient to take time off. And once again, we try to take care of them expeditiously without any unnecessary visits. And the ability to avoid permanent bladder injury is, I think, short-term loss, taking time off work, for long-term gain, long lifetime preservation of bladder function, no trabeculations, no bladder stones, no UTIs, and no catheterization ever. Because keep in mind that one of the procedures that we do here in the office, the way I do it, requires, most of my patients do not even require a catheter. And I'm talking about the UroLift system. I performed 6 of these procedures today. None of the patients walked out of here. They literally walked out of here. None of them walked out of here with a catheter. So even though you are not concerned, the patients are extremely concerned about having to wear a catheter. They are also concerned about sexual dysfunction. And this procedure does not cause any permanent sexual dysfunction, including no retrograde ejaculation, which is very, very common when you prescribe tamsulosin or also known as Flomax in the past. And the patient's bladder function's preserved. And if you think about it, it's kind of like uncontrolled hypertension, right? Uncontrolled hypertension, the patient eventually develops cardiomyopathy, and guess what? The cardiomyopathy does not ever recover. Once the heart muscle is injured, it does not get back to normal, no matter what kind of rehab you do. Same thing with the bladder. Once injured, it doesn't return to normal, ever. So my goal as a urologist is to preserve bladder function, preserve kidney function. And the worst cases, thank goodness, worst cases that I see are very rare, meaning the patient's bladder's completely failed, the bladder's so distended it goes up into the level of the umbilicus, and there's hydroureteronephrosis. So chronic obstruction, incomplete bladder emptying, hydroureteronephrosis, completely asymptomatic until you do a BUN and creatinine and realize, oh my gosh, the guy is in complete kidney failure. And then that is the worst case that I've ever seen. Thank goodness, not many of these over the years. Worst cases that I've seen where the guy ends up on dialysis, having to wear a catheter all the time, all because of BPH. So no, you are not going to offend me by sending your patients to see me. You're not wasting my time. As a matter of fact, you are probably saving your patients' bladders and their quality of life. And they can get off of 1, if not 2 different medications that are nothing but Band-Aids. All right, any questions or comments? Feel free to leave them below. As usual, I welcome them. Take care, and do not delay sending your patients to the urologist for the treatment and management of BPH. Bye-bye.